I want to spend a few minutes talking about simulation instructor roles. We've talked a lot about the moving parts and the layers of simulation. So we're going to talk about each individual role that can be had during a course from the instructor side of things. So the first role that you would have is the course director role. So this person is basically coordinating all the faculty and some of the participants as well. So what we've done is we've put before scenario, during scenario, and after scenario kind of columns and what each task is for this role underneath each one. So before the scenario, the course director should ensure all the simulation roles are filled. So that includes the participants as well as any Confederates, who's running the console, who's going to be answering the phones, all of the roles to make sure that we've recreated reality are filled. You want to think about any potential unanticipated actions by participants and have a plan to work through. So it's that contingency plan that we've been talking about. Assigning specific participants to scenarios. So again, not every participant is going to be in every scenario. Sometimes they'll be watching the scenarios live. So you want to think about who's going to go into which scenarios and when as the director. You want to get the participants to a specific start location and provide them with general information. So whenever we set the stage for scenarios, we have the scenario set in the sim room. We have the participants somewhat waiting in the wings, and so they're primed and ready to go. We call them in when everyone's ready to go, and then they start the scenario. And we give them a briefing on, a couple sentences as to what they're coming into. Before you start the scenario, as the director, it's really important to make sure that everybody is ready to go. So you've got the cameras ready. If you're filming, you've got the mannequin vital sign set, the Confederate has their microphone on, all of those little details that need to come together to put a scenario together. During the scenario, you're going to, again, coordinate the entry of the participants into the scenario. So you'll go gather the participants and bring them in. You're going to coordinate the activity in the control room. So you need to change the vital signs, you need to attend to the call lights, maybe you're going to be the patient voice, or maybe somebody else is going to be the patient voice. You need to make sure that role is covered, and you might designate specific camera shots if that's applicable for your area. You also want to determine the end of the scenario. So as Aleka mentioned, that's really important to know your endpoint and have a couple of different endpoints if you think it could go a few different ways as well. You want to coordinate the end of the scenario with a debriefer to make sure that all of their debriefing points have been covered from their perspective as well. And then, as Aleka mentioned, we always say, thank you very much. We will continue the care of the patient from here. Please make your way to the debriefing room. So generally, the course director is the best person for that role, and they help guide the participants into the debriefing area after the scenario. So that's the last column. Confederate actor role, Allison went through quite a bit of this, so I won't go into this in detail. But again, it's knowing the learning objectives from your point of view, knowing what your role is so that you can act accordingly during the scenario. You want to act in your specified role and be aware of overacting. It's really easy to overact. It's a tendency that we all have. And you want to help guide the participants and locate supplies and equipment as needed. Sometimes we'll put Confederates in the debriefing afterwards if they have the time. A lot of times our Confederates are actually doing the room turnover as well, so they're not always in the debriefing, but they do add an interesting aspect because they've been in the scenario firsthand, kind of on the same level as the participants, and so they see things that we don't see because the control room actually gets really noisy when you're running scenarios, and so sometimes you might not hear everything. The mannequin console operator, so this is the person that's running the mannequin, running the computer. Before the scenario, again, you want to turn on the mannequin and make sure that you have all the associated patient monitors up and running, the touch screens are enabled. You want to make sure that the mannequin is functioning properly, so you've got the outputs as far as green mannequin if you're using classic, you're getting breathing, pulses, all those inputs are set and working, and then you may need to troubleshoot as needed. You want to set the patient's initial vital signs from the scenario template. And then during the scenario, you're going to use the cues from the scenario template as well as any cues from the director to help alter the scenario based on the interventions of the participants. After the scenario ends, you want to basically end the scenario and reset the computer. That may mean turning it off for a break or just putting it on pause and resetting the vitals. We talked a little bit about troubleshooting. 3G, we didn't touch on too much, but it does tend to overheat, the 3G mannequin. So after about 4 hours, it actually gets quite hot on its back. And so what we do is, it's recommended to turn the mannequin off, and what we do is put it on its side, and if it's really hot and it's a hot day outside, we put a fan next to it as well, and just let it kind of cool down over lunch, during the lunch period, because what happens when he overheats is he loses connectivity, and so that can really mess you up if you're running a scenario at the time that he actually loses connectivity. The classic and the sim baby mannequins tend to work fairly well with that pause and then restart option. The patient voice role, this is a lot like the Confederate role, but they're usually back in the control room, away from the scenario per se, unless they are a standardized patient, then obviously they are the standardized patient. But if you're using a mannequin and you want them to say more things than just hello or I'm tired, or the general responses that the mannequin can give, you can set up a walkie-talkie, or if your sensor has the capabilities, you can use the headsets if the mannequin has that capability as well. So there's a few different ways you can do the patient voice. So the main thing to do is to set up the application prior and test it, because simulation has a lot of feedback loops. There's a lot of technology going on, a lot of audio competing for the same space, so to speak. And so you sometimes will get these feedback loops where things start to squeal. So you want to always test the volumes and bring down the volumes as needed. As the patient, you want to obviously review the learning objectives of the case and act accordingly. So during the scenario, if you have a high respiratory rate, then you're going to try to talk with a high respiratory rate, and so it makes it, more real. You want to also be aware of on-off buttons, whether it's a mannequin that like 3G that wears a headset, or if you're using walkie-talkies, being sure that you turn it off when you're not speaking so that they don't get feedback from the control room, because that could be a real problem if you're assessing their performance. You don't want to let them know about that. Again, beware of electronic feedback. So you might want to turn the volume down lower, or you might want to step away from other electronic equipment. Sometimes helps. And sometimes holding the electronic equipment further from your mouth also does help as well. And then, of course, just turning it off at the end of the scenario. Videography role, touch on it briefly. This is important to see yourself from a different perspective, but it adds an extra layer of work when you are debriefing to start and stop the video. So it's kind of an advanced skill. But before the scenario, again, you want to review the learning objectives so that your camera angles follow where the movement is and the action and what the learning is based on. If you want to do a close-up of a procedure, you can try to zoom in. Be mindful not to kind of zoom in and out as you are doing the filming if you're doing a handheld camera, because it can be disconcerting for the people watching it in the debriefing. Let's see. Again, you have to make sure that your AV is working appropriately. You might want to have a backup plan. A lot of people use GoPros. Again, we don't advertise anything here. We tend to use our own AV system that we have in place, but GoPros I've heard are quite handy because you can just videotape and put it on a tripod and then just plug it into your computer. So that's kind of a pretty good way to get at least one overview angle. Let's see. Again, during the scenario, you're going to coordinate with the director and the console operator to capture those key events. So maybe you want to zoom in on a procedure, or you want to show a shot of the vital signs if you don't have, a 4-way screen or a 3-way screen and you just have one camera. Take intermittent shots of the vital signs so that when you play back the debriefing, or people that are watching can get a clue as to what's going on with the patient progress. You want to make sure that you know the start and the end time of the scenario as well, so that you can coordinate with the rest of the team. Depending on what kind of videography you're using, we do have video that's live in the room and here, so some of the participants that aren't in the scenario are watching it live. So as soon as the scenario ends, you want to make sure that you turn this view off of the sim room, because that's when the team comes in and turns the room over, and so then you can go into your debriefing mode. And then, of course, making sure that your video is destroyed within policies, within, university or hospital policy. The setup and clear up of the room, this is often done by our Confederates. They wear multiple hats, as we all do. And again, these are suggested actions for each role, but most likely we're going to be combining roles. You might be a mannequin operator and the videographer. You may be the director and the debriefer. You may be the Confederate and the room setup and tear down role. So there's flexibility. In a perfect world, if we had 7 people, and there's 7 roles. Before the scenario, set up the simulation room as directed by the scenario template. So all of that information on your scenario template is very useful for the Confederates and also the people setting up the room. So as much detail as you could provide, the best. You want to have moulage, IV drain lines that we showed you, any supplies and equipment that are going to be needed during the scenario you want either in the room or just outside the room so they're readily accessible. Any props you want in the room, have that there as well. If it's cognitive aids or if it's flowers, somebody's in a nursing home, you want to set up the stage as far as they have their watch box and pictures and flowers. So just think about the scene that you're in, and then after the scenario, clean up crew. So again, cleaning up your mannequin quickly after any moulage is quite important for staining, for bacterial loads. So you want to try to do that as much as possible, empty any drain lines. It might be good to be on a regular maintenance check and cleanup of your mannequin. So obviously check to make sure all the functionality is working, as well as making sure that the skins are cleaned appropriately, just for longevity of the mannequins. And then finally, we've got the debriefer role. This is a very important role because we know in simulation most of the learning actually doesn't occur in the simulation, but it occurs in the debriefing. When we talk about mental frameworks and try to get on the same page as far as what happened in the scenario and why did you make those decisions and how can we be better as a team. So before the scenario, again, it goes back to your learning objectives, always knowing what the learning objectives are. No matter what team member you are, that's always important. Making sure that you're in a position to hear the scenario and see the scenario is really important as the debriefer. Whether you're in a purpose-built center and you're in the control room or you're off to the side behind a curtain, it's always good to be able to peek around and see the action live. During the scenario, you want to take notes of any key events that have happened. We utilize notes, checklist. I don't think we do that enough in healthcare, and it's important that even as debriefers, we're not the end-all be-all. We can't have all the information in our head. We can't see something, put it in our head, and then integrate it for the whole group. Sometimes it's okay to write notes or take checklists, and it's really important when you're just starting out in debriefing to have those checklists at hand and refer to them. There's no harm in that. A tip that I always use or tell people about if they're an early debriefer is to have preformed questions. So you've got your learning objectives. That's what's really guiding your debriefing. So just create a few preformed questions based on those learning objectives that you can plug and chug in right away. Because we know when we get up in front of people, it's very easy to get the deer in the headlights. Uh-oh, I'm on stage now and I have to come up with something. So if you have some preformed questions, it's a really handy reference, or use a cheat sheet. During the scenario, you want to focus on learning objectives. Are they being met? Any unanticipated actions by the trainees. So things that you didn't anticipate but happen and that are going to be important in the debriefing. And then, of course, the crisis resource management skills that we talked about, those 7 key skills that really break down in crises. After the scenario, hopefully you have a fellow debriefer that you can bounce ideas off of. You want to meet with them for a quick catch-up. Make sure that you guys are on the same page. Maybe one of you wants to tackle cognitive and technical issues and one wants to focus on behavioral components. You want to have a quick coalesce, but get to the debriefing as soon as you can, within 1 to 2 minutes if possible, because we find that participants will debrief themselves. They've come out of the scenario, their emotions are high, and they will debrief themselves. So you want to get in here and start the debriefing and or video, if you're going to use the video in debriefing, as soon as possible. You want to also know the about length of time that you've been in the scenario. A general rule would be about a 1-to-3 ratio. So if your scenario was 10 minutes, you want to spend about 30 minutes on the debriefing. That's a pretty good rule of thumb. And then again, start the video pretty quickly, within 3 minutes for sure. Any questions? The next thing we're going to do, and you're going to have a discussion on debriefing in a moment, I'm going to show you a video that we put together of a scenario. So it's 8 minutes long, and there's a Confederate in it. It's basically a 45-year-old patient, excuse me, that fell into a kind of a green waste brush fire at their house and got burnt. And so you'll see paramedics in the video, you'll see a physician, 2 nurses, and you'll see a family member as well. So just wanted to show you this as mainly as an example of a Confederate, but also if you can pick up any of these different roles that you see during the scenario, and we'll talk about, okay, which roles were obvious during the scenario. But mainly it's a view of the Confederate. So focus in on Chris, who happens to be our Confederate family member, and how he goes throughout the 8 minutes, and where he ramps up and where he pulls back. Kind of those subtle nuances.
So we got a 45-year-old male patient who was burning some green waste in his backyard. He tripped over his brother's dog, who then ran towards him because he saw the accident happening, pulled him off. We don't know it. We don't know it. He talking to us. He applied some cold water to all of his burns with a garden hose. The patient suffered some partial deep burns and some full thickness burns on the left side of his chest. He also suffered some superficial burns on both arms, both hands, on the top side of both legs. So overall, we're looking at about 27% of burns on the patient.
Star, can you feel for a peripheral pulse?
Yeah, sure.
The initial vital signs were
BP 170, pulse 110, and respiratory 24.
So our treatment was we supplied with 100% medical oxygen with 15 litres a minute.
I can feel it. It's
We
weight
also-
there.
And
Let's
we
get
also,
some fluids into him.
Okay.
Lactated ringers, did you give him any fluid?
yeah, we gave him some
How
fluids.
much?
Oh.
This on his toilet. Sorry, darling. Okay, BP 100 over
How much has
70.
come out of that bag of 1 litre?
Sorry,
Star?
excuse me. Pardon?
How much fluid's come out? Just get some more.
Oh, Jesus.
Yeah, sure.
We gave him 1 litre of Ringer's fluid.
One, okay, cool, perfect.
Sorry, has he got a cannula in now? Sorry.
Yeah,
Oh, yeah.
14 gauge in the right anti-fuel muscle.
Just gonna take this. Sorry.
I put water on his chest
Oh,
and I got.
We're sorry guys, because we got another call, so we'll need to head off.
Okay, alright, sure.
You're not going to go now, are you?
Oh yes, because we need to save another
You've
one.
got the lactated ringers.
Yeah, that's great.
Great, no worries.
Yeah, that's
Should we put a catheter in at some point?
Yeah, sure.
Thanks, thanks very much.
Alison, can you listen to the breath sound?
Yeah,
Come on, Mikey. Jesus Christ.
Thanks, sweetheart.
This is crap. He fell over a fucking dog. Look, he's burnt to a crisp.
No, no, I'm sorry.
He's going to be alright, isn't he? He's going to be alright, isn't he? He's going to be alright, isn't
We're just assessing him at the moment.
he? Yeah.
Oh, sorry, sausage. I know that's sore. There is breath sounds on both sides.
Okay, what's his oxygen saturation like?
87.
87, okay. I'm going to proceed to intubate. Alison, can you get me some succinylphonium, ketamine and propofol?
Yeah, sure.
And Di, can you grab the bag of mask?
Yeah.
And
Sorry,
while
Mum.
I set up
Yeah, sure.
for intubation.
Can I touch him? Mikey, come on.
Right, I'm just going to ask you to step out of the way just 1 minute just so that I can help your brother, okay?
Alright, we've got some nasal prongs.
Mikey! Come on, Mike, can you hear me, mate? Mikey!
Let's just put these ones straight up. And if you can get me the RSI trolley, please. Yeah, sure.
Oh,
Sorry. Mikey!
Drugs are here.
Mikey! Come on, lad. I'm not going to touch him.
Do you have drugs on me?
Thank you. You got those drugs?
Drugs in here.
Right.
Yep. Can you give them?
Yeah, sure. Are you ready?
Um,
Are you guys ready? Have you the drugs?
well, don't give the stuff just yet.
I put water all over him, so that's going to help, isn't it?
Yeah,
It's going to help, isn't it?
Yeah, of course, of course. You did everything. You did.
I did.
We're doing an RSI.
We're doing an RSI, yeah.
Okay, so I'm going to put profiles.
What are you doing
in.
now? What's this?
We're just going to help him with his breathing a little bit, so a little bit worried he's
Yeah.
inhaled from the smoke.
Are you ready for the break? Yeah, sure. So I'm going to put profiles in. Yep, profiles going in.
This is alright, isn't it? This is alright here.
And you want the ketamine as well?
Yes.
And let me know when it stops. Ketamine's going in.
Mikey!
That sounds great.
Mikey!
Go with, get that stuff in there.
Okay.
Like that.
Are you ready for the crank? Yeah.
Yep.
Okay, so.
He is still breathing, isn't he? He's still breathing, isn't he?
And we need the suction rate crank on it.
What are you doing?
High blood pressure crank now.
I'm just going to put a little tube down his throat to
Yeah.
help him.
High blood pressure on
Help
it.
him breathe. Yeah.
Oh!
Okay, suction's in.
No, come on!
Position.
Mike,
It's vesicular.
that's not right. Why is it?
Oh, do you want to pop that on?
Is he fitting? Is he fitting?
No, he's not fitting. He's just from the drugs that we've
Okay,
got
so-
to help him with his breathing.
Oh.
So I've got a stethoscope and have a listen for me, please.
Can we pop this in, then we can get a
Yes.
seal.
Mikey, come on!
Sorry, I thought we had waveform.
Oh, fuck, this is not right. There's only a fucking dog.
We've got capnography.
It's going to be alright, isn't it? It's going to be alright. Tell me it's going to be alright. It's going to be alright. Will you tell me it's going to be alright?
Yeah, she's like doing everything we can.
Alright, can we organise a ventilator? Someone spoken to RFDS about transferring
No, shall I do that now?
Major burns, that would be great. Can you come back and tell me when you do?
Yeah.
And how?
Is that helping? What's this doing?
Yeah, it's helping.
Hello,
He's
it's
feeling
someone
his
who
chest
messaged
is
me.
right.
I'm
What's your name?
sorry to could we organise a
So we're just helping
medical
Michael
transfer of a
breathing
45-year-old
for a moment.
patient to regional burns?
And we're organising to get the aeroplane to take him to the major
Okay, thank you,
burns
bye.
in town.
You've got a CO2 trace and you're happy.
And happy, yeah, the sat starting to come up.
Yeah, that looks good, isn't it? That looks good.
Yeah. Jack, can you organise for a ventilator, please?
Yeah, sure. Oh,
And
sorry, I
a white
forgot, sorry.
That's okay.
Oh,
Do you want us to go in?
where's she going? Can you get some more people?
She's just, yeah, she's going to get some more help.
Come
She's going to
on.
go get a machine to help with his breathing.
This is not right, is it? This is not right. Oh.
Right, their stats are coming up nicely.
Come on!
Good going on.
This is...
So, Chris, can you tell me a little bit more about Michael?
He's fine, he's sitting there, just having a lark, we're just doing something in the garden.
Yeah.
He tripped over a fucking dog, for God's sake, the fucking dog, I want to kill that fucking dog.
So he tripped over, I think he
He
tripped over the
just-
dog and
He was only in the fire.
fell into the fire. You put the garden hose on for him?
Yeah,
That's
loads of
really good.
water.
That would have been really helpful.
No.
We just take the temperature as well, make sure he's warm.
Oh, alright.
Have a sit down. Is he allergic to anything that you know of?
No.
Chris?
No.
Is he taking medications?
No.
No.
Ventilator's on its way, doctor.
Thank you. Could you take his temperature, please?
Sure.
It's going to be alright, isn't it? You know what you're doing here?
Might just put some
So we showed that video just to somewhat highlight the role of a Confederate. So you could see that our Confederate kind of came forward and pulled back a number of times. And so he gauged the clinical scene and the participants and kind of knew when to step forward and ramp it up and knew when to pull back. It's kind of a nuanced skill that watching the scenario you can kind of pick up. We talked about during the debriefing his role within the scenario because he was actually added into the scenario. It took it from a cognitive and technical scenario to a real behavioral component. And how do you deal with family members and when is it appropriate to pull away from clinical care and address the family members, and how would that have impacted the care of the patient and the care of the family member? Because it wasn't till about 8 minutes in that he was really calmed down and sat down and had that talked to from the staff members. So the debriefing dynamic changed completely because of the addition of the family member. Do you guys have any comments on the scenario or the Confederate?
It's really powerful. Like,
It's almost real, isn't it?
Into it.
Yeah. It's almost you get dragged into it like it is real.
Yeah.
Yeah, and it makes it very real for the participants as well. I don't know if Allison wants to speak to it from a participant perspective.
I just felt so bad that he kept asking for just this little crumb of reassurance and knowledge, and we were focused on his brother, and you could hear him getting more and more distressed the more we sort of ignored him. And it's just my personality type. I find it very challenging to ignore somebody that's so openly distressed. So all my sort of critical thinking skills just went out the window, because every time I did something I'd think, I must go and talk to him, I must go and talk. And then when he started swearing, I was thinking, oh, are we ever going to sort of, if this was a bit, well, it felt like a bit situation to me. I just thought he could start hitting out because he's not getting what he needs.
And that's for me, it was too long before someone did. I would have had to have gone earlier. But not knowing the actual being involved in the scenario, you know, was that airway such an issue that you had to put that person and leave them and ignore them?
Yeah.
But for me, I find that very hard, ignoring family or other people outside. I will go to that person and hope that one of my team members will then continue on.
Yeah.
So for me, it felt such a long time.
In a real life situation, would you not stabilise the patient before, even though it is very distressing for the relative?
Well, these are the things that we spoke about during the debriefing after this scenario, and that fine balance of helping the family member, but making sure that the priorities of care for the patient are met as well.
And the other thing is, you didn't know what was going on, you didn't at the time, and you're not supposed to give them false hope, are you, either? So that's a fine one.
We used a couple of cliches like we're doing everything we can.
Yeah.
Things that we say that we hope will comfort people, and we're very open to interpretation.
Yeah. And we also talked about nonverbal cues during the debriefing, and our body language and positioning and eye contact, and how does that impact our care with the family members, and being cognizant of that. And watching yourself back on video, you see the mannerisms that you do that you wouldn't otherwise know. But just talking about timing, for most of the people in that scenario, it didn't feel long because they were in it. So it was about 8 minutes, but what did it feel about? Did you say it felt about 4 minutes or something?
Yeah,
it was very short.
Going on.
So when you're in simulation, time warps. When you're in a real life crisis, time warps as well. So some things are really stretch out and feel really long, and some things are really fast. So when you add in other layers and dynamics like that, it really changes the look of the scenario, but also what you get out of the debriefing as well. So that's just an example.
It's very good how you've got the surroundings though to make it look like it is you're in ED.
Yeah.
Really good.
And a couple of things that we noticed that we probably wouldn't do in real life is that Aleka asked for the drugs. I didn't check what dosage they were because I knew there was loads of drugs I'm familiar with. I also didn't check when they came in, and it's just so easy how drug errors.
Because you have to shout out the expiry date, don't you, normally? So,
Oh,
or at least
everything's
verbalise
checked,
it loud
checked,
or
checked,
something.
checked. Didn't ask did he have any allergies, and yet he's a guy wanting desperately to be involved in the conversation. We just didn't say has he got any allergies, or we're giving him some pain relief. It was just very focused on patient care, really.
When you were setting that scenario, how much guidance or direction did you give?
Was that you? Was it Chris? Yeah.
To perform in that role, or was his experience such that you just like yourself out, have fun?
Pretty much, we did give him a script, so to speak. We do tend to get a script beforehand, but we tend to just run it on the fly as how things go. If we're getting too ramped up, then we'll be advised, just
Pull back.
chill for a minute, pull back, or if we're not, acting up appropriately, it'll be just ramp it up.
And who does that come from?
That's
Someone in the
from the
control
control
room?
room.
From the control room, yeah.
Did you have an earpiece on then throughout?
Mm.
You should have an Oscar, you did very
Mm.
well. It upset me watching it.
It's really important to pilot your scenarios as well if you have the time, because there's a lot of things that you might miss if you just did it in front of others, or in front of participants or with participants that you wouldn't normally catch if you had kind of done a dry run through. That might be equipment that you didn't anticipate that they would want, or maybe the Confederate would take it into a different level than you may have thought. So it's good to pilot it if you can, and to give a script to the Confederate as much as possible.
So the paramedics and the people who met everybody, I recognised a few people, but it was all a scenario that you knew each other. Because in the real
paramedics, and I didn't know the paramedics. They were students that we brought on the day.
Right, that's what I wondered, whether, because the paramedic, you could see he was a little bit flustered by it all, wasn't he?
Yeah. And that's what you're going to get.
He was a student. I didn't know if he was the one who was being tested in bringing the patient in and doing a handover, or...
No, it just sort of...
That's what I felt like as
Yeah,
well.
he might have been the student.
Yeah. But even if it's maybe not students and healthcare providers mixed together, you're going to have different levels of trainees. You're going to have the experts, you're going to have junior staff that come together, hopefully as a multidisciplinary team. And so oftentimes during the debriefing, it's that expert thought process that doesn't get talked about that's really important for these junior staff members, because when we know how to do something, we just do it. We don't think about it. It's human nature. We just go ahead and do it. We don't talk it out. We just do it.
And in a
But
real
the junior
life
staff,
scenario, there'd be 7 or 8 of you as well. Like you say, you'd love to have loads more people.
yeah.
Because you wait all the way through that, you're waiting for more people to arrive to go, what can I do? What can you know what I mean?
But what do you do if that help doesn't come?
Yeah.
If they're on a met call, or they're busy in another area, or they're just, like paramedics, that's it. You're it. And if your equipment doesn't work, then too bad. You've got to wait for backup crew. You've got what you've got on the day, and you're with who you are with those skills, and you've just got to work with it, really. That's just like real life, isn't it?
It is. I'm sure at 9/11 they sort of had to differentiate who was, who to go to first and who was more likely to survive and not, kind of thing.
Yeah, well, these are the sort of things that we try to prepare people for. We try to not prepare for your worst nightmare, but what awful scenario would you hate to go into work or walk down the street or even go home to, when we try and, if we can recreate that, so that if you do come across something like that, you sort of psychologically think, well, I've done this, I've trained for this, this is what I'm going to do. Quite often in aircraft crashes, they'll say that air stewardesses were lovely, they were amazing, I just took over, and they'll just go, I was just doing my job, I didn't think about it, because I've been trained for it.
Yeah. It's that over-preparedness that they talk about in aviation and aerospace that we're trying to get to at this point in healthcare. That second nature.
And realising that everybody has a voice in everything. People don't often want to speak up because it can still be quite hierarchical. I don't want to ask the doctor, he should know what he's doing. Or there's presumption that people should know what they're doing, or they should have that knowledge. They may not want to voice it, and everybody has got something to offer, even if you don't think you have. You've all got a voice, you all work as a team. We had the police over one day, and they ran a scenario, not here, but in their village. They've got a little village out the back, it's just magnificent. And they put some explosive in the microwave. And everyone's like, how are we going to do this? And they had all these senior guys saying, we're going to do this, we're going to do that. And there's apparently the probation just went, sorry, pulled on somebody's tag and went, excuse me, and they're like, yeah. And he was going, no, excuse me. No, we're going to do this, we're going to do that, we're going to shut the road off, this, that, and the other. Went, why don't we just turn the power off? And you can't turn the microwave on, can you? And it was just a completely, not an underthinker, but a completely new perspective.
That's incredible.
Yeah. And it just, everybody's got a voice, everybody's got something to offer. Even if you give somebody emotional support, you still, everybody's got something to offer.
And everybody has blanks, don't they, where everything just leaves them and you need somebody else somewhere to go. What about this? Yeah, that's where I'm going.
And that's what we try and hope to foster, that people will speak up, and people,
Have you seen that? I hope it's not in here. I was just telling Lauren before that. Just another routine operation.
Yeah, we show that in most of our
It's
courses.
amazing. I show it all the grads that come through and they sit there like that.
Makes you cry, doesn't it?
Oh, it's awful, and that man's so brave. You've got to Google it. It's on YouTube. It's called Just a Routine. Have you seen it?
What's it called?
Just a Routine,
Routine
Operation.
You should write that down if you haven't seen it.
Seriously,
Yeah.
it'll.
See you with a glass of wine and a box of tissues.
Yeah, and at the end, think what a brave man.
You're so humble as well.
And he was
isn't
proud when you were going on about this aviation thing, and that's what
Yeah.
made him. Yeah.
Don't, because you make me cry.
No, it was very sad. Every time I watch it, I cry.
It's true though, isn't it?
But it's silence when you turn it off. There's just silence in the room afterwards.
Yeah.
It's a different mentality though. They train for errors. They know that we're humans, and they train for those kind of occurrences, and so that when they do happen, they're prepared. We haven't got there in healthcare quite yet.
Why?
I think it's that mentality that we just have to do everything right, and we have to do it well, and we are the sole person. And it's the blame culture that we have still. I mean, other thoughts is
Everyone's different. So it's slightly the same, but then it's different. So then you become biased, I suppose, from previous experience.
I suppose also if there's a flow chart to follow kind of thing in any scenario, then that's been put together by experience and people have been there, done that. So hopefully it will eradicate anything being missed, I like the ALS thing kind of thing. And if you do it for aviation and try and implement it in other ways, because we do, especially senior doctors and anaesthetists and things like that, it's like, could possibly be me. Do you know how long I've been working? You know what I mean?
Yeah, and sometimes they're not aware of changes.
Or even it wasn't my fault. I did everything about it, and instead of taking ownership to learn from it, kind of thing.
It's also a number of staff.
Yeah.
It's easier to, 2 and or 3, however, when you have 7 or 8 or 10 or 12 in a room.
Yeah. And how often do you think people will actually be quite honest and just go, actually, I'm not sure. I'm not sure about that. I don't want to do that, or I'm not very familiar with that. It takes quite a lot to say
A
that.
lot of that PMH, a lot of our doctors will say, in like a code on the wall, they'll say, I don't know what's everyone else thinking.
Oh, that's great. Yeah.
And
That's
they'll sit
great.
there, and it might, like you say, just be someone who's like, actually, have we thought about
Yeah.
this? And if you've got nothing, then at least you know then you've all got nothing.
Yeah.
Rather than someone being sitting there knowing an answer.
Yeah.
I think that's the standard, but that's not what's being practiced in hospitals throughout everywhere, not just Australia, but
Depends on culture as well, I think.
each hospital has its own culture and hierarchical system.
Yeah. And even within private and public healthcare, it's different hierarchical system.
In the UK, we used to have 2 intakes of junior doctors into our ED department, 1st of August and 1st of January, and the first thing they always got told was, if you don't know, ask one of the nurses. They've been here like years, the kind of thing, and it's hard for them to because they want to be seen as the leader in the club, you know what I mean?
Yeah.
That one, but they're told to.
Yeah, and sometimes there's that bullying culture as well, like, well, you're the doctor, and you think, oh, bless them.
Yeah, it's just come
We've
out of
all had
medical
to learn.
school.
Yeah, sometimes people forget what it's like to be new, to be unfamiliar, and to be scared, and be in that difficult environment.
And remember that each healthcare profession has its own identity, its own professional goals, it has its own things that are important to them, the core values, and things, physicians may be more numbers driven, more outcomes driven, nurses, I mean, these are generalizations, but nurses may be more relationships based, so there's differences in the way we're actually trained as well that comes into play with these hierarchies. So we have a socialization within our professions, and we know what, I'm a nurse, I know what my role is, I know what my job duties are, I know what my values are, but do I really know what a physician's are? I mean, maybe I have a vague idea. Do I know what a paramed's goals are, what their values are, what their job duties are? There's not that overlap of knowledge about interprofessional teams, but yet we come together and we work in interprofessional teams. So that, I think, plays into the hierarchical nature and the society, the blame game, and it's complex.
But we like